Good morning, good afternoon, good evening, everyone. It's Dr. Kaz here coming in with our third and final installment for human development. And we're going to go right into what is now going to be the portion of the human development cycle in which we are getting ready to welcome the fetus, soon to be baby, into the world. In order to do that, we have to engage in the process in which we call labor. So what exactly is labor? Right. Well, labor is when we are going to physically remove the fetus or expel the fetus and the placenta, right, from the female's or the mother's uterus here. Now, normally the full term or what we consider to be the proper amount of time for a baby to develop is going to be 38 weeks. So usually anywhere from 38 weeks to 40 weeks is a full-term pregnancy here. And so usually around that time is when we will start to see, right, uterine contractions to occur. Now, important factor is not all, let me repeat that, uterine contractions are considered to be true labor, right? True labor. We'll get into the different types of labor, but true labor, right, is not necessarily going to be, well, I should say, all uterine contractions aren't necessarily going to be considered true labor. And so when the mother starts to experience contractions, they will start to experience them at what we call a slow and low or weak and irregular, right, frequency of contraction. So in some instances, these contractions can occur in the late portions of the second trimester, but really when it's time to get ready for the baby to be born, actual true labor, this is going to be in the third trimester. And what we'll see is during this time, we are going to see increasing amounts of estrogen and oxytocin. And we've talked about both of those hormones extensively in previous chapters, but we will talk more about oxytocin here coming up in just a few. So our first type of labor is what we call premature labor, and this is going to occur prior to our 38 weeks, our full term pregnancy period here. And so ideally, we do not want the baby to be born prior to 38 weeks. We mentioned this in previous videos, how the body systems are still developing, and there's those crucial periods of time in which we get that peak development period for a lot of the systems here. And it's just like, I hate to compare it to this, but it's just like cooking a meal in the oven. You don't want to take it out of the oven before it is cooked appropriately. And in this case, we don't want the child to be born, the fetus to be born when, right, all the body systems aren't fully developed. It's not ideal. And we hear so much, usually about premature births. Usually one of the organ systems that we get especially concerned about is the lungs. Obviously, we know that we need the lung development for proper breathing. And so, of course, the more premature the fetus is upon birth, the higher the likelihood of increased morbidity and mortality rates can occur. So premature labor is something that we try to avoid, obviously. And then we have our false labor. And so our false labor, we will see uterine contractions occurring, but we're going to talk about the 3 stages of labor here in a moment. But in our false labor, we're not going to have all 3 stages of labor to occurring with false labor. So Braxton Hicks, we've heard this, most people have heard about Braxton Hicks contractions from time to time. And so a couple of the characteristics about Braxton Hicks contractions is that, one, okay, these types of contractions are irregular spaced and they do not become more frequent. True labor, right, the contractions will become more frequent here. Also, we do not see an increase in intensity. And again, with true labor, we will see an increase with intensity as we are getting ready to expel the fetus here. Braxton Hicks will normally see the pain in the lower abdomen, whereas with true contractions, we can see pain right in the upper abdomen region there. And with Braxton Hicks, we will see sometimes when the mother is moving around, right, we can get a cessation there to the Braxton Hicks contractions. And so true labor, we won't see that. And then finally, there are absolutely no cervical changes occurring with our Braxton Hicks contractions, right? Which, again, with our true labor, we will see changes in the cervix there, which we'll talk about here momentarily. Okay, so let's get into the true labor, right? So with true labor, our uterine contractions will increase in both intensity and frequency. And so they'll start to adapt somewhat of a regular, you'll hear folks saying, oh, we're timing the contractions that are, this far apart. And usually they'll say, if you notice a decrease in between the periods of contractions, timing wise, that means that that baby is going to be coming sooner, right? As that period shortens in between contractions. So we need to get mother to a birthing center or in a safe place for the mother and child to be united, all right, or reunited, but outside in the world, okay? So what we're gonna see with true labor, we're gonna see mom's hypothalamus is going to be secreting, all right, high levels of oxytocin, right? And oxytocin is going to be responsible when we're dealing with the uterus, right, with contractions of the uterus. And also, not too many people know about the fetus here, the fetus's hypothalamus will also be secreting oxytocin. And that oxytocin from the fetus is going to have the same effects on, all right, the uterus as the mother's oxytocin. So both of these sources here are going to stimulate the placenta to secrete prostaglandins. And if you recall, prostaglandins are eicosanoids, right? Just like prostacyclines, leukotrienes, right? Those are locally acting hormones. And so these substances are going to do a couple of things. One, they are going to continue or stimulate uterine contractions because we got to get ready, getting ready to expel the fetus, but also it is going to what we call soften and dilate the cervix, and which basically, all right, the cervix is the inferior-most portion of the uterus. And so what we're going to do in that scenario is we are going to, one, thin out the cervix there and dilate the opening there of the cervical canal to prepare for the expulsion of the fetus there. And so when we see, right, both fetal and maternal, all right, secretion of oxytocin from both of their hypothalami, right, this is where we're going to then jump into our true labor. So a couple of things that we're going to see with true labor, and we saw with the Braxton Hicks contractions that those were not considered to be true labor. We saw with Braxton Hicks, right, the frequency of the contraction does not increase. Well, here with true labor, it does increase. So the frequency will increase, all right, with the contractions, and the intensity will also increase. We'll also see with our Braxton Hicks that we saw lower abdominal pain, right? Well, in this case, right, with true labor, we're going to see upper abdominal pain, and it will radiate down into the lower back. Pain will not go away upon movement, as we did see with the Braxton Hicks. And also we said or saw with the Braxton Hicks, there will not be any cervical changes. Well, guess what? True labor, that's not the case. With true labor, we are going to see cervical dilation. So we are going to see that cervix start to thin. The opening of the cervical canal will widen and open up, getting ready for the baby. And then we'll also see with true labor, once the contractions are actually causing the fetus to be expelled, we'll see the expulsion of the fetus, and we will also see the expulsion of the placenta with true labor. Whereas in false labor, you don't see any of that. So way, way, way back at the beginning of this course and throughout several chapters, we've discussed negative and positive feedback mechanisms. And so our true labor is an example of a positive feedback mechanism. And a positive feedback mechanism is that the effector or the result of whatever the stimulus is going to further promote that stimulus. So we'll talk about its effects on breastfeeding here in just a few moments. But when we're dealing here with actual labor, all right, we are going to see that as long as the fetus is in the uterus and its head is pressing up against the cervix, that is going to facilitate, right, our contractions of the uterus. And also, it is going to further cause stretching and dilation of the cervix up to 10 centimeters there. And so as this is occurring, right, the head of the fetus pressing against the cervix, that's going to cause, right, the hypothalamus in both mother and in the fetus to secrete more oxytocin. And as we are stimulating the release of more oxytocin, then that is going to stimulate the placenta to release more prostaglandins. And so those prostaglandins are going to help further dilate the cervix up to 10 centimeters, but also we are going to see more intense uterine contractions. And so there's some drugs that mimic oxytocin. And there's a drug out there called Pitocin. And that's a very common drug in which they'll administer to mothers to induce labor. And pretty much that Pitocin is going to cause all of these effects in which I just mentioned here. So this will continue on and on and on, as does most positive feedback mechanisms, as long as the stimulus is there. So we have to remove the stimulus to end our positive feedback mechanism. So all of this happens until the fetus is expelled out of the uterus. Once that occurs, the head of the fetus is no longer pressing on the cervix. We're not going to see the increased release of oxytocin being released from the hypothalami of both mother and child. And so once that occurs, we will see, all right, uterine contractions decrease and our cervical release, all right, of prostaglandins and that thinning and of the dilation of the cervix, all right, we're going to see now all these stimuli being reduced, right? And so eventually all of that causes labor to stop or cease. So this picture here, I look at this picture and, probably the thing that interests me the most, and I know this is kind of goofy when I say this, is the expression on the mother's face. You would think that she'd be smiling, but I don't know too many mothers that experience smiling during labor. So that's what I'm thinking here, that this model here is currently undergoing labor. So that's why there's no smiling, just kind of a sidebar here. But you're seeing here in this slide here, several different aspects to the positive feedback mechanism of true labor. All right, so we're seeing that as the baby is pressing against the cervix here, the fetal head is pressing against the cervix here, right? That is going to cause, all right, the release of oxytocin from the mother's hypothalamus and from the baby's hypothalamus. And so that stimulates the release of oxytocin. All right. Well, sorry. That causes the release of oxytocin. And so that release of oxytocin will do a few things. One, it is going to directly cause the uterus to contract, but also it stimulates the placenta there to make those prostaglandins. And so those prostaglandins will also help to contribute to contractions of the uterus. But those prostaglandins will also help with dilation of the cervix there. So we can now start to open up this space here for the baby to then be expelled through the birth canal there. So let's talk about our 3 stages here of true labor. So the first stage is the dilation stage. And so you've heard up into this point that whenever I've been mentioning dilation, it's usually in reference to the cervix. So that's what we're going to see here. Right. So with our dilation stage, now we're going to see our uterine contractions adopt what we would consider some sort of regularity. right? They're not infrequent. We are now able to see some sort of pattern of regularity with our uterine contractions. And now we're going to start to see some effects in the actual cervix. So there's two terms that you want to be familiar with. You've heard me mention dilation, right? So we're going to start to see that cervical canal there start to widen. And so therefore we refer to that as the dilation. And so ideally, we're going to dilate that opening up to 10 centimeters. Then the other term when we're dealing with the dilation stage is effacement. And so when we're referring to that, what we're talking about is the actual cervix is going to thin, right? So it won't be as deep as you would remember. I mentioned it, the cervix before as like a donut. So we're going to see a thinning of that cervix, so it won't have that kind of that depth to it before. So you'll hear terms of effacement and dilation. So this stage is the longest, and so this one also has the largest amount of variability. And so we'll see that between women that have not had birth, and we call those nulliparous, and then we have women that have given birth called parous. Now, first time pregnancy and labor delivery here for nulliparous women, we'll see that their stage will be longer, and it ranges anywhere between 8 to 24 hours. Whereas with women who have given birth before, right, this stage will be shorter compared to those that have never given birth. And so that can be anywhere between 4 to 12 hours in women that have given birth before, parous women. So with our dilation stage here, we have that regularity between the uterine contractions, but mind you, right, we are seeing that ever increasing amount of intensity and frequency in these uterine contractions. And as long as, all right, the fetus's or the baby's head is resting or pressing against the cervix, this will continue, all right, the increasing intensity and frequency of these uterine contractions, and also will progress through effacement and dilation of the cervix there. And this is the phase 2, or excuse me, the stage in which you hear women will say, oh, my water broke. And that water breaking is the rupturing of the amniotic sac there, and that's going to release that amniotic fluid. Now, in some cases, this may have to be manually done, right? Because for whatever reason, we're not getting, all right, the rupture of the amniotic sac. And this too, when they've ruptured the amniotic sac, this will also help to move and progress into the next stages here of true labor. So you can see here in our picture, right, you can see the beginning part of that dilation stage there. And you'll notice, all right, the cervix has not dilated completely, all right, but we are seeing some thinning here. Right, so there's just not enough room for the baby to progress out. So as we progress through this stage here, now you'll start to see further widening of further dilation here of our cervix there. We get up to 10 centimeters, then mom is ready, all right, to start to move the baby down through the birth canal out through the vagina here. So the second stage of true labor, that's the expulsion stage. And if you look at the name of that, that tells you exactly what's going to happen here, right? We are going to move, all right, the fetus out of mom. So at the end of this stage, baby has left the building, so to speak, all right? The expulsion of the fetus has occurred. So once this stage progresses, right, we have the cervix has completely dilated up to that 10 centimeters. 10 centimeters is the measurement, right, that we use here. And so the expulsion stage, again, it varies, doesn't have as much variability as the dilation stage, but anywhere between 3, all right, to many hours afterwards. You've probably heard stories in which people have been in this stage for quite some time, all right, but like I said, we are going to see that this too also has some variability occurring. And so women, if this is their first pregnancy and first birth, all right, the nulliparous, all right, this again will be longer. here's where we're going to see, right, during the expulsion stage, right, in which the uterine contractions are pretty frequent, and they're pretty powerful. And so this is where the doctor or whoever is assisting in the delivery process will start to say things like push, bear down. And basically what they're doing is they're taking advantage of the Valsalva maneuver. That is when you increase the intra-abdominal pressure through a closed glottis there. And that's what they're asking mom to do now, is to increase that pressure to help facilitate the expulsion of the fetus, right, out of the mother, out through the vagina, through the birth canal there. So when we're looking at the expulsion stage, we're going to notice a few things. You've heard this term crowny, possibly if you've ever had anything to do with childbirth. And this is when you see the top of the baby's head, all right, the calvarum. That is when it starts to make its appearance there, all right, in the vagina, and it's starting to, you'll see, I'll have a picture here in a moment that you can look at, in which you can see, all right, the baby starts to emerge out of the mother's reproductive tract here. And so ideally, right, we want the head to come first. Much easier to birth a child when the head comes first, right? Unfortunately, if it's not the head first, right, if it's the rear end, right, or a breech delivery, then we run into some possible increased risks of delivery, but ideally head first is where we want to go. And also there's a term here called episiotomy, and this doesn't necessarily have to happen every time, but in some cases, depending on how big the head is and how much of distension occurs with the vagina, all right, we would rather surgically cut, all right, the area that's inferior to the opening of the vagina between the anus there. And so we don't necessarily have to go all the way, but sometimes they'll make a surgical incision there in case they're more concerned that there could be some tearing or ripping there. If there's tearing or ripping there, we become concerned because there could be some damage there. But a surgical incision, less likely here. And what that basically does is it just makes a wider opening here for the baby to emerge from the birth canal there. And then finally here, this is where we will clamp off the umbilical cord, tie it off, and then cut the cord here. So here you can see, right now, as the baby, as we are in our expulsion stage here, the baby starts to move through the vagina, aka the birth canal here, and you can see as the crown of the baby's head starts to emerge here out through the vaginal opening, hence we call it crowning. And then as soon as we get the head, I mean, really, once the head is kind of out, the rest of the baby is relatively, by comparison, easier to deliver depending on the position of the child, because those shoulder joints and the other, usually if you get past the shoulders, it makes it a little bit easier because things are usually a little bit more slender after we get the shoulders out there. All right, and then finally, for our true labor stages, the final stage is the placental stage. And so once we got baby out, we still have to finish up here and get the remaining, all right, tissues and organs of the development of the baby from mom. And so the placental stage is when we get the rest of the placenta, or not the rest, but the placenta out of the uterus here. So this obviously will occur after the fetus has been expelled. And then during this time, mom will still continue to experience uterine contractions. And there's a couple reasons for that. One, we want to compress all those uterine blood vessels, right, between the uterus and the baby, the placenta there, right? So we want to compress it. We don't want blood flowing there anymore. There's no reason for that because the baby has been expelled, and we don't want to risk bleeding, right, of the mother. So this will occur, and then we will expel what we refer to as the afterbirth, which is the placenta and any fetal remains there, or not remains, excuse me, any fetal membranes left there. And so this will occur after the baby has been born here. And so after this, when this occurs, all right, the medical staff will carefully examine the placenta, make sure, one, that they got all the remaining material out of there, because one of the concerns that the medical staff has will be bleeding out of the mother. So now that baby has been born, we have to figure out a way to feed this child. And so, as luck would have it, lactation takes care of that process. Right? So lactation, definition is production or release of breast milk from mammary glands. So back in chapter 28, we learned about those mammary glands and what causes the mammary glands to start producing breast milk. And so one of the things that causes that is the hormone called prolactin, made and released from the anterior pituitary. And it is going to cause milk production in our breast, in mother's breast material. Now, when someone is not pregnant, this includes men, okay, they produce dopamine. And so dopamine, right, is going to inhibit milk production in non-pregnant women and also in men. And we will also see prolactin levels increase when we have high levels of estrogen. And we've discussed this before in our reproduction chapter, in which we discussed when estrogen is released in high levels, what effects it has on breast tissue here. And so prolactin is going to cause that milk producing tissue, all right, those acini in the breast tissue, it is going to cause an increase in proliferation of those acini, the structures that actually create the breast milk, and we will see, all right, an increase in the branching of the ducts there that go from the acini out to the nipple here. All right, so the first substance that is produced by the mammary glands is called colostrum. And so we see this production occur in our late pregnancy, so third trimester, and this is what mother will produce the first couple of days once the child has been born. So this is not going to be the same type of breast milk that mother is producing, 1, 2, 3 months after giving birth, right? This breast milk, all right, has a lower concentration of fat. But what it does have is it has lots of antibodies, immunoglobulins, especially IgA. So we discussed back in chapter 22, active and passive immunity. And this is that passive immunity that mother gives to child, right? This is how the baby's immune system is able to deal with, all right, certain infectious agents, all right, early on in its life outside of the uterus here. Also, all right, and parents that have had to deal with this, it also produces a laxative effect. So it makes, when the child starts to have bowel movements, because their early bowel movements are more like a tarry type of thickened material, this helps to facilitate, all right, an easier time when the infant is experiencing its first several bowel movements here, helps to kind of get that whole digestive system, especially the distal end of the digestive system, working appropriately. And it gives the parents that, I won't say lifelong, I hope not, but it also gives parents that, the beginning of diaper changing, that wonderful experience with that. So once breast milk starts to come in, right, we are going to see a larger or higher fat content than what colostrum had. And of course, I've mentioned this before, fat is a highly desirable substance, all right, especially in developing infants, right, that your body will gladly take in, right, because it helps build up tissue and it's a great source of energy. So this high fat content, all right, is great for fatty acids. We talked about all the uses for fatty acids, but also enzymes, right? We need to start to give the baby, all right, the proper enzymes that it needs for proper digestion, and it continues on, all right, containing immunoglobulins, which is great. So you'll notice once the colostrum has left and breast milk has come in, all right, for the baby, you know, their bowel habits and the consistency of their stool will be much different here. And so breast milk is ideal, all right, for the baby, right? But of course, in some instances, baby cannot nurse properly, or mother has an issue with that, with nursing. So we have to go on formula, which is a breast milk substitute. But breast milk has shown to be much easier on the digestive system of infants than some of the breast milk substitutes here. All right, so it has been often said that breast milk is the optimal source of nutrition for an infant. Doesn't mean that if somebody was taking formula in that they're not going to develop the same way. All I'm saying is that from studies and whatnot, breast milk is more ideal. So milk letdown, you've heard of this process here. This is when we are going to actually feed the child here. And so we talked about this a little bit when you first started taking this course back in chapter 1 and in chapter 17. All right, we are now dealing with another positive feedback mechanism. We saw it with the uterine contractions. Now we'll see it with our milk letdown. So in the breast tissue around the nipple, we have mechanoreceptors. And so those receptors become stimulated when the baby is suckling on the nipple there. And so that stimulus is then going to send sensory input information to the hypothalamus. The hypothalamus, again, is going to produce that oxytocin. And so that oxytocin is going to be released from the posterior pituitary, and it's going to head out to these specialized myoepithelial cells. Myo being muscle, right? These are a specialized type of epithelial cells that can contract and relax, and it can cause, all right, the movement of breast milk from the acini there. And it moves it into the lactiferous ducts, and then in out of the breast and into the baby there. And so this causes that release of milk as the baby is nursing here. And so because of that, as long as the baby continues to suckle on the breast, then that will stimulate this process, this positive feedback mechanism process in releasing milk. So that's what this picture is showing us here. All right, a lot happening here. All right, so the stimulus is the infant suckling there, stimulating those mechanoreceptors. And so the mechanoreceptors are sending information or sensory input information to a couple of areas here. One, right, it's going to send that sensory input information to the hypothalamus. And so that's going to prevent the release of dopamine or prolactin inhibiting hormone, right? So we no longer need those high levels of dopamine to inhibit the release of prolactin. And so that suckling then causes the release of our oxytocin from the posterior pituitary, and that stimulates those myoepithelial cells to contract to release that breast milk as the baby continues to suckle. That's that positive feedback, right? That positive feedback. And so this occurs as long as there's this stimulus, which is the baby suckling on the mother's breast there. And so milk letdown, we're going to see that if you were to track this, that every time that the baby breastfeeds, we'll see a spike in prolactin production here. And we see that on this graph below here. And so because of that, right, every time that prolactin is produced, all right, that will then stimulate the cells in the breast to make more breast milk. And so as a result of that, we are going to inhibit dopamine release from the hypothalamus. So that won't inhibit our production of prolactin. And so as long as that occurs, then that inhibition of that dopamine, then we can create large amounts of prolactin, like you can see here on our graph. Every time, all right, that baby is nursing, we see a big spike in our prolactin levels there. And we also will notice too, one of the things, and again, it's not something that you should definitely hang your hat on all the time, right? But during lactation, during these feedings, this period of breastfeeding here, we'll see an inhibition of ovulation. And that is because we have inhibited the gonadotropin releasing hormone. And if we don't have this hormone, then we will not have follicle stimulating hormone or luteinizing hormone being released. They will not be released. And so this, of course, will prevent ovulation. All right, so keep that in mind. As long as, and it's not 100% guaranteed, all right, it all depends on the fluctuation of the hormone levels, especially when we're dealing with FSH and LH, right? But for the most part, right, there's a pretty good chance, right, that we will have prevented ovulation, right, as long as breastfeeding is occurring. Well, folks, I hope you enjoyed, all right, this last chapter, chapter 29 on human development. It has been a pleasure having you here with me on this ride. I wish you all the best of luck.